Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihil kareem. I'm going to talk about, as my colleague Saima very eloquently presented, the causes of sudden death in young people. And this is not something uncommon. We see in our practice every day around us. So I have my special interest in the hypertrophic obstructive cardiomyopathy patients requiring surgery. So I'll take you through about what HOCM is and how it presents, how do you investigate HOCM, and a few more details, and then about surgery as well. So, surgery for hypertrophic obstructive cardiomyopathy. So what is HOCM? HOCM is an asymmetrical thickening of the interventricular septum. This is a condition in which it's a complex condition in which it affects the heart muscle. It increases markedly, and the heart muscle becomes thick and becomes stiff as well. It also leads to mitral valve changes and the cellular changes at the myocardium level. It's a dynamic obstruction at the level of the left ventricular outflow tract, which is due to asymmetrical hypertrophy of the interventricular septum. As you know, in hypertensive hearts, you can develop a gross left ventricular hypertrophy. That's nothing to do with the HOCM, because that does not causes any obstruction at the left ventricular outflow tract. So in this condition, there is asymmetrical hypertrophy of the interventricular septum right at the, this is the left ventricular outflow tract through which the blood is pumped while in systole. This is mitral valve, this is left atrium, that's aorta, that's aortic valve. So when the heart contracts, the blood is pumped out through the left ventricular outflow tract, through the aortic valve into the aorta. So when the heart contracts, the muscle is asymmetrically enlarged here, so that causes obstruction at this level. So there is an obstruction to the flow of the blood, and the left ventricular cavity is small. This has different names as well. It's also called hypertrophic obstructive cardiomyopathy, hypertrophic cardiomyopathy, or idiopathic cardiomyopathy, subaortic stenosis as well. These are different kinds of cardiomyopathies. You might have heard of different cardiomyopathy. This is a normal heart. As you can see, this is healthy left ventricle, healthy septum as well, and it pumps enough blood to the body. This is dilated cardiomyopathy. You can see the whole ventricle is dilated. It is not hypertrophied. Muscles are weakened, the whole heart is enlarged, the heart size increases. It is not as effective in pumping the blood out of the heart. The whole ejection fraction of the heart is reduced as well. So that's the enlarged ventricle. On to the contrary, where there is a hypertrophic cardiomyopathy, that includes the hypertrophy of the ventricular muscles. The whole muscle becomes very thick, especially at lateral wall, the septum as well, and resulting in less blood flow because the cavity becomes small as a result of hypertrophy of the ventricular muscles. This is what it looks like. This is a diagrammatic representation. This is the left ventricular cavity, left atrium, and this is the mitral valve here. This is the interventricular septum. As a result of a thickening of the left ventricular interventricular septum, it causes obstruction between the mitral valve and the septum. So as a result, when the heart contracts, they come together, and there's a pulling of the anterior mitral leaflet as it causes a hose effect. It's just like you imagine, the water hose when you just water your grass, and when you press the lever, the water just rushes out of the hose. This is exactly what it is. As a result, this causes a hose effect and pulls the anterior mitral leaflet, causing the increased gradient below the aortic valve. What is the reason for that? Most of the time, the reason is unknown. It's idiopathic. Etiology is not known. It is genetically determined as well, and it runs in the families, and the primary muscle abnormality and it can be acquired due to hypertension. That doesn't lead to obstructive pattern. There are figures different in parts of the world. In United Kingdom, I've got the figure 10,000 people in the United Kingdom have been diagnosed to have HOCM as well. What happens to the mitral valve as a result of the dynamic obstruction at the left ventricular outflow tract? As I just mentioned before, when the outflow tract is narrowed, the blood rushes through the outflow passageway towards the aortic valve. It just like a tight garden hose, as I mentioned before, drags the anterior mitral leaflet and causes further obstruction, and is called SAM, systolic anterior motion. The increased force of blood, it pulls the valve open and causes mitral regurgitation of different severities as well. There are changes at the cells level. The myocardial muscle cells are also affected. They are disorganized, they become irregular, and this irregularity or disarray of the cells have an impact on the electrical activity of the heart, leading to different arrhythmias, especially ventricular tachycardia or ventricular fibrillation, which could be lethal. As Simon mentioned earlier, such patients do require an implantable cardioverter device as well. How do they present? They may have no symptom. They might just be picked up on a routine echo for different reasons, or they may not have any kind of symptoms whatsoever. They can have exertional breathlessness. They become breathless on exertion. They can have a chest pain on exertion as well. A few patients whose obstruction is very sizable or the gradient is very high, they present with syncopal attacks, dizziness and blackout, especially when people go to sajda in prayer. When they get up, all of a sudden they experience this blackout and maybe dizziness as well. Palpitation due to arrhythmias, about a quarter of these patients, and these symptoms could be so profound that leads to disabling lifestyle as well. And yes, it is one of the sudden cause of death in young athletes as well. And how the whole disease is progressed over the course of the time. Yes, it's a disease of the second and third decade, athletes, young adults. It could be asymptomatic to become symptomatic or clinical HOCM. People can live with at least 30-40 years without being very symptomatic. So you can have an HOCM as a part of your family, and you can be asymptomatic till it becomes clinically important or significant HOCM. So age second to third decade, the symptoms are progressive over the period of time, and you cannot live a normal life without a surgical treatment or a proper treatment. Some studies show there's 15% people die at 5 years, and about a quarter of these people die at 10 years. So it's a very, very alarming and a very, very sizable figure if this condition can be diagnosed. The natural history of patients with HOCM, this is the obstructive without any surgical treatment. This is the years, and these are the overall survival. So the survival curves goes down over 10-year period of time. About 40% people are they can experience sudden death as well. So if you have a non-obstructive HOCM, sometimes it is possible, they live longer, and you perform myectomy and relieve their obstruction, they can live longer due to the treatment. How do you diagnose these people? So they must be tricky. This is not something which everybody can just pick up on a routine examination with these conditions. So these conditions do need special tests or routine tests by expertise who deal with these people who are dealing with structural heart disease, the cardiologists who are looking after people with genetic disorders as well. So cardiology is not only treating angina or putting stents. The cardiology covers the whole aspect of any cardiac abnormality, electrophysiologist, structural heart disease cardiologist, and then you have a cardiologist who deal with genetic disorders as well. So this is one of those conditions. So echo is the most commonest, simple, non-invasive test. Anybody can have echo. Everybody usually has an echo. So it can pick up these things, or the HOCM and the gradient. You can provocate these tests by sitting down in a squatting position and ask the patient to do Valsalva maneuver and get up. The moment you get up, the intrathoracic pressure increases and leads to increased dynamic obstruction. The stress echo can be performed, angiography can be performed, and you can do the ventriculogram to see the increased muscle. Of course, transesophageal echo is useful as well, and magnetic resonance angiogram or imaging is very useful in diagnosis of HOCM. MRI, cardiac MRI is nowadays available most of the places in big centers. This is what it looks like on the transthoracic echo. This is the left atrium, that's the mitral valve, that's enlarged, thick interventricular septum. That's the outflow tract, this is the aorta. So this is where, this is the leaflet, this is the muscle. So heart contracts like this, they come together and cause the obstruction at the outflow tract. So again, echocardiographic picture, that's the increased muscle. Usually it's about 12 to 13 millimeter is the width of the septum, but in HOCM it can lead to about 25, 30 millimeter, which is about 2.5 to 3 centimeter. And this is the mitral valve, that's the aortic valve. So this is where the causes this obstruction. That's another ventriculogram to show the end-systolic LV. And again on MRI, it shows the RV, LV cavity and thickness of the muscle as well. And this is the different varieties and modalities to see the extent and the level of the obstruction, whether that's at the outflow tract, mid cavity or the apical. You can have the obstruction at different parts of the heart, either at the outflow, maybe in the mid cavity or in the apex of the heart as well. So the treatment depends on how bad is the obstruction, how bad is the gradient, what is the LV function, what is the patient's symptom, how symptomatic the patient is, and of course the age and activity level of the patient. If somebody is very elderly, 85, his activity is hardly more than what he's supposed to do in home, going to washroom and eating and all other, looking after himself. And so you have to see what are the requirements of the patient and the presence of arrhythmias or history of sudden death in your brothers or sisters or your family. That's a very important determinant of treatment. So the aim of treatment is to prevent symptoms, the complications, the risk identification. Regular follow-up is very important. Lifestyle changes, of course. You have to change your lifestyle. If you have a HOCM, unfortunately, you cannot play rugby, you cannot play football, you cannot do kabaddi. So you have to modify your lifestyle. So you can't do these kind of sportive activities. So it doesn't mean that you have to be a couch potato. No, that's not what I'm suggesting. But you cannot do very strenuous exercise if you have. You cannot be an athlete. So this is something is not for you. Yes, medications and sometimes intervention is required. Medical management, as you all know, combination of few Smarties. I call these tablets Smarties. I'm sure you all know M&M and Smarties. Anyone who doesn't know M&M and Smarties? So if you just take few M&Ms, different colored pills, either they're sweet or no. So this medical management is all about choosing different colored pills. Like anesthesia had a white syringe and a clear syringe. So in medicine, it's all about different colored pills. So you choose different M&Ms and Smarties. So beta blockers, it reduces the workload on the heart. Antiarrhythmics, of course, if you have an evidence of arrhythmias, it prevents the arrhythmia. So you have to give some antiarrhythmics. Calcium channel blockers as vasodilators help the reduction of the workload as well. And diuretics do help, and ACE inhibitors. So what you can do as a surgeon, there are two mainstays of treatment for HOCM. One is the cardiologist can do some septal ablation. I'll take you through that, what septal ablation means. And from surgeon point of view, you can do resection of that increased asymmetrical muscle at the level of the left ventricular outflow tract and make the passage through the outflow. So you can do septal myectomy, which is the gold standard. This is TASH, transcoronary alcohol ablation of the septal hypertrophy. So what you do, just like in angiography, you go into the coronary left anterior descending artery, go into the septal branch if you find one, and you inject alcohol. It causes the infarction over there, as you can imagine, and leads to shortening of the muscle as a result of infarction. But it does have a lot of complications like arrhythmias or other complications. If the muscle is very, very thick, this is not something which works. Sometimes you have to replace the mitral valve if the mitral valve is badly affected. Combination of treatments, myectomy and replacement of the valve. And of course ICD implantation if it is required, if there is a history of things. This is alcohol ablation into the coronaries, go into the septum, and you inject alcohol, which causes infarction, and this muscle gradually, as a result of infarction, reduces in width and leads to some help into the relief of the obstruction. Only done in very specialized centers by people who do this regularly, because it's very difficult. Sometimes you don't have very formed septal branches for these patients. This is what the myectomy looks like. So this is aorta, left atrium, left ventricle, right ventricle. So through the aortic valve, so trans-aortic resection, a wedge resection of the muscle of the interventricular septum and increase the tread. So you relieve the obstruction. This is what it looks like. Why surgery? Not because we are surgeons, we like to cut everything, no. This has been the gold standard treatment for myectomy patients with HOCM who do not respond to medical treatment or who are extremely symptomatic and have arrhythmias or history of sudden death in the family. The surgical resection gives the more or less the flexibility of resecting the septum and direct vision, which you can do. It achieves the complete relief of the subaortic obstruction, given the complex anatomy of the left ventricular outflow tract. Symptoms are relieved instantly, immediate, and they're permanent and virtually complete. 90% of patients, they improve by at least one NYHA class. The quality of life improves straightforward. It does improve on long follow-up. Survival improves, as you can imagine. The risk of arrhythmias and sudden death reduces. A long-term release of the sudden death is reduced as well. Historically, if you look at the surgical history of this condition, we used to call as myomectomy. Myomectomy is cutting of the muscle, and then it became myectomy. The first guy who performed this procedure was Morrow, who actually devised this procedure, and since then it has been the mainstay in the treatment of refractory, severely symptomatic patients with obstructive form of HOCM. Then there's an extension of Morrow-Bigelow, where you have extended myectomy of the interventricular septum. So surgeries for medically refractory patients, young subjects who are otherwise in good health, if symptomatic patient, in spite of all the medical therapy, and the gradient is above 50 millimeter of mercury. If you've been on medical treatment for a long time and the gradient is high, if they remain asymptomatic or have only mild symptoms, myectomy would then be performed for progression of symptoms. One exception is young, otherwise healthy patients who present to you and they have a very high. So you don't have to wait and put them on a medical treatment. They are the ones who benefit from relief of the obstruction. This is what it looks like. The first operation I performed, alhamdulillah, in Pakistan when I came over here. You're looking through the aorta. This is the aortic valve, this is non-coronary cusp, this is the right coronary leaflet, and there is the left coronary leaflet here. So you're looking transaortic into the left ventricular cavity, and by pressing the LED with this sponge holding forceps, the septum comes into the view, and then you make a little slit here, one here, and then you take a wedge. This is the wedge which is coming out away from the interventricular septum. This is where the septum is. All surgical colleagues know this. At the junction of the right and non-cornicus, there is interventricular membranous septum. So away from the membranous septum, you make a long cut, right, and then like this, and you take a wedge at least 2 centimeters, as much as you can go down into the ventricular cavity. So this is what it looks like before the surgery, and then after the surgery you resected that part of the interventricular septum. You can have combined procedures sometimes. You have to do others, people suffering from coronary artery disease, you have to perform CABG, and if the SAM is too bad and mitral regurgitation is very, very gross, you have to either repair or replace the valve. Replacement is better because you don't leave any more chance of any SAM afterwards. And transesophageal echo is very useful intraoperatively and postoperatively to assess the efficacy of the myectomy. And if bypass grafts are required, you have to. So what the evidence is about this procedure? The non-randomized studies indicate it provides a long-term survival benefit of this disease, and superior to non-operated people who have got severe obstruction. In the 7th World Congress on Heart Failure in Vancouver, they presented this different maneuvers and modalities of people treating for HOCM as well. Biventricular pacing is another option where you desynchronize the ventricle. So they contract asynchronically, and that relieves an obstruction as well. So if somebody is very unfit and you cannot have a surgery or ablation, you can do the biventricular pacing, and they asynchronize the chronicity of the heart as well, and leads to some relief of the obstruction with medical therapy as well. And so this is several surgical and non-surgical techniques for reducing or abolishing the symptoms of HOCM were reviewed, and they looked at and they said that this is another one which is at the Cleveland Clinic. They presented their experience of the HOCM patient. Cleveland and Mayo Clinic have got the biggest experience in Cleveland, in America. They have done thousands of patients with HOCM, and so they got the largest series on HOCM patients. They get patients from all over the world who go there. So there are people who have done hundreds, a few hundreds of HOCM procedures. Not every cardiac surgeon does these procedures as well. So they looked at between 1994 to 2005, 323 patients, isolated septal myectomy. So effectiveness of the myectomy was assessed by echo, sudden death, functional limitation, early risk by intraoperative and postoperative complication, and the risk by follow-up for HOCM related operations, heart blocks. So they looked at for nearly 10 years. What they found, myectomy was effective, resulting in sustained decrease in the septal thickness and the gradient at the outflow tract, and absence of sudden death improved functional status. Effective in eliminating the obstruction and risk of sudden death, improves the functional status with the low operative mortality and morbidity. Few operations are required late, and outcomes are very excellent. So it should be considered the treatment of choice for HOCM. One of the longest operations I have performed here was in 2006. The guy is, alhamdulillah, still alive. And the other patient was alive for 7 years. He died of brain hemorrhage for different reasons. So he was totally symptom-free for many, many years after HOCM. So then another Mayo Clinic experience I'd like to share with you. This was presented in 2007, and they looked at the gold standard treatment of this condition, and in almost all circumstances the mitral valve had some abnormality, and there was abnormality of the subvalvular mitral apparatus. I probably have to skip few slides because I don't want to bore you into a lot of data as well, because that's for a lot of cardiologists who want to understand because many people still believe that there is no surgery can be performed for HOCM, and this is not possible, and it's very people don't get better, it's very risky. So this is why I've got all the information and evidence for these procedure, that why this procedure is done and what are the benefits and why this is a useful procedure. So I'll just present you with an interesting case. This was my first HOCM I performed, alhamdulillah, in Pakistan, and this guy was turned down by almost every center in the country. He had a known coronary disease, had an angioplasty to circumflex artery, developed instant restenosis. Diagnosis of HOCM was made, and his gradient was 95 and extremely symptomatic. With even coughing, he used to become dizzy and blackouts kind of thing. So he had a coronary angiogram, developed two vessel disease as well, extremely symptomatic. His life is miserable due to symptoms. So medial stenotomy is the most common approach. Open heart surgery, establish the cardiopulmonary bypass. You can't do it on a beating heart, unfortunately. You cool the patient down if you want to. Nowadays we cool less patients compared to we used to, and I use cold blood cardioplegia. Preferably I use antegrade and retrograde, but recently with more and more performing this, you become more quick in these procedures, so I only give one shot in the beginning because the aortic valve is competent. But I do have an option of either retrograde, and sometimes if I'm chickened out or my preference armies, that you can give it to the coronaries as well. It's only one more shot you need to give, so I can give into the directly coronary, which I don't like giving to coronary myself, I don't know why. And oblique aortotomy is performed through the aortic valve, so trans-aortic approach. Again, the same picture you saw before, and that's how you take the wedge out of the septum. That's what it looks like. After, you can see that you have relieved obstruction by taking the wedge. It looks very small here, but effectively in a contracting heart, in a beating heart, it means a lot. This is after resection. So perform the CT angio to see the grafts, patency, and the vein was patent as well. This is another CT angio of same patient. We were having some symptoms, so we wanted to check. There was some disease developed in one of the vein grafts as well. Up to date, alhamdulillah, I've done, this was about a few months ago, we performed another 3 surgeries after these 20. So we got about 23 patients I've operated for the years I've been in Pakistan. This was I presented 3-4 months ago with 15 male, 5 females. Age was between 26. The youngest one was 26. A young guy who's an accountant in Kuwait. So my colleague Dr. Aftab Yunus referred that patient to me. So I can say that some surgeons do refer that patient to me as well. So I've got exceptional 2. One Aftab referred, and one of the surgeons from Pindi recently referred a patient. So that's a good ice breaking as far as I'm concerned. Wedge myectomy was performed then I performed mitral valve in 2 cases, and one was the cabbage and myectomy as well. First patient required pacemaker, and because being a first patient, I wanted to achieve as much as possible, probably, as you can imagine, because the guy was turned down by every single person. He happened to be the president of the union of the bank employees. I never realized that how many people were standing outside the hospital. About 400-500 employees union people were there. So probably I wanted to achieve as much as results. So we ended up having a pacemaker. None of them had a stroke or renal failure. One patient had a slight bone infection, which was just treated conservatively with my antibiotics. No further treatment was required. One patient who was very sick. She was extremely moribund, but young lady. I had no choice but to operate on her. The operation went very well. She died about a week later with multiple things she developed, but she was almost inoperable case as far as the symptoms were concerned. The reason I wanted to give her a chance, and the patient herself wanted to take a chance. She said, I cannot live like this on a wheelchair, sitting, bending your head forward all the time and coming to hospital every day. The operation went very well. She developed so many things, one after the others, and eventually arrhythmias killed her, sadly. The follow-up is with clinical echoes, and I get a CT in certain patients as well. So I would like to conclude, yes, they need to be diagnosed. Somebody has to diagnose HOCM. Yes, once you diagnose, you need to know what else to do, what next to do. Patient referral issues is a very important thing. Of course, fears. Most of the patients who come to me, it takes me at least a month to convince them this can be done. So they go and check everybody, they go and meet every person, they check every single thing. They want to talk to patient, they ask about me, they ask about everybody. They're extremely frightened. And then, of course, the expertise is required for your team, your perfusionist, your anesthetist, your assistant. There is a team of people who does this job, and long-term need for ICD in certain patients as well. This was the, some of you do recognize some of them. And this was, I don't know what Aftab is pointing at. Yes. Stag was part and parcel of, this was the first operation I performed, and Alhamdulillah, most of that team is still working with me, so I'm so pleased that somebody found that. And in those days, I think Celine Dion's song was very popular, My Heart Will Go On, so somebody there. Well, I think you all know that this is something very common. Yes, it's good to have a condition which can be treatable, but sometimes it's not good to have a rare condition. It's called good health. If you have a good health, that's a blessing of Almighty Allah. I wish you all well. Thank you very much.